All right, welcome back to Discussions with Dr. G, where I make pharmacology just a little less terrifying and a lot more sarcastic. I'm Dr. G, and today we're talking about the heavy hitters in labor and delivery. So let's kick things off with oxytocics. You've probably heard of oxytocin or Pitocin if you're on a first name basis. It's basically the Beyonce of L&D meds. Everybody wants it, but not everybody can handle it. We use it to induce or augment labor, and it's also a go-to for postpartum hemorrhage control. But, and this is a big but, it can cause uterine tachysystole. That's more than 5 contractions in 10 minutes. Basically, the uterus is throwing a rave and forgot to invite the baby. Worst case scenario, uterine rupture. Not fun. And don't forget about fetal distress, because if the uterus is working overtime, the baby may not be getting enough oxygen. Oh, and if you're running high doses with lots of fluids, watch out for hyponatremia. Water intoxication is not the plot twist you want in your shift. Now, oxytocin isn't for everyone. If your patient has previous uterine surgery, like a classic C-section, or there's fetal distress where vaginal delivery isn't safe, just say no. And if you're using vasopressors, you're looking at an increased risk of hypertension. So what's your best friend here? Continuous fetal monitoring. Seriously, if you take nothing else from this episode, remember, oxytocin means you're glued to that monitor. Titrate carefully, and if you see hyperstimulation, turn off the oxytocin. Give some oxygen and reposition mom. Oh, and keep an eye on intake and output for water intoxication. Now, let's not forget misoprostol, also known as Cytotec. It's great for cervical ripening and off-label for postpartum hemorrhage, but it can also cause uterine tachysystole and some lovely GI distress. If your patient's had prior uterine surgery or there's a non-reassuring fetal heart rate, skip it. And if tachysystole happens, do not give another dose. I repeat, do not. Methylgonervine, or Methergin, is your friend for postpartum hemorrhage from uterine atony. But if your patient has hypertension or preeclampsia, this one is a hard no. Always check that BP before you give it, and if it's over 140/90, walk away. And then there's carbaprost, or Hemabate, for hemorrhage that laughs in the face of other meds. It's effective, but the diarrhea is memorable. Contraindicated in asthma and hypertension, so always ask about those. Pre-medicate with antidiarrheals if you can, and keep an eye on respiratory status. Now, let's flip the script. Sometimes we're not trying to get the baby out, we're desperately trying to keep the baby in. Enter tocolytics, terbutaline, nifedipine, and the old standby, magnesium sulfate. Terbutaline is great for stopping preterm contractions, but it can make your patient feel like a hummingbird. Tachycardia, tremors, anxiety, and even hyperglycemia. If your patient has cardiac disease or poorly controlled diabetes, you're going to want to steer clear. And if their heart rate goes over 120, hold the dose. Oh, and if they're diabetic, make sure you keep an eye on their glucose. Nifedipine. If you recognize the name, great, since this is technically a calcium channel blocker, but we use it off-label as a tocolytic. Watch for hypotension, headaches, and dizziness. If your patient's already hypotensive or you're thinking about giving it with magnesium sulfate, just don't. The combo can tank the blood pressure, so monitor BP, change position slowly, and have some headache management tips ready. Now, magnesium sulfate. This one is a classic. We use it for neuroprotection in preterm birth, sometimes for tocolysis, and definitely for seizure prevention in preeclampsia. The big risks: flushing, warmth, respiratory depression, and hyporeflexia. If you see loss of reflexes, that's your red flag for toxicity. Keep calcium gluconate at the bedside because it's your antidote, and check those reflexes and urine output like your license depends on it, because honestly it does. And don't forget glucocorticoids, betamethasone and dexamethasone. These are the unsung heroes for fetal lung maturity in preterm labor. They can cause hyperglycemia in mom and sometimes fetal bradycardia, so use caution in diabetics. Monitor blood glucose, educate about those sugar swings, and give it IM in a big muscle. At about 31 weeks, I went into preterm labor. They started me on mag sulfate and a dose of betamethasone, just in case. Luckily, the labor stopped and I was discharged. Better to be safe than sorry. Let's talk pain management, because labor pain is, well, legendary. We've got butorphanol, meperidine, and fentanyl in our arsenal. Butorphanol is great for moderate pain, but if your patient is opioid dependent, it can trigger withdrawal. And if you give it too close to delivery, you risk neonatal respiratory depression. Always check the cervix first. If delivery is imminent, just don't. And keep naloxone handy always. Meperidine or Demerol isn't as popular as it used to be, mostly because of neurotoxicity with repeated dosing. Think tremors and even seizures. Plus, it can cause neonatal respiratory depression, so avoid it near delivery and in patients with epilepsy. If you have to use it, go low and slow, and don't repeat doses if you can help it. Fentanyl, rapid, short-acting, it's great, but the respiratory depression is a real risk. It's safe for epidurals, but watch for hypotension, and again, keep that naloxone close. Timing is everything. Give opioids too close to delivery, and you'll have a sleepy baby on your hands. All right, future RNs, here are some safety pearls. Oxytocin always means fetal monitoring. Tocolytics buy you time, but it's not a miracle. Magnesium toxicity, loss of reflexes, know your antidote. Opioids near delivery, sleepy baby. Always ask about asthma before giving Hemabate, and never give methylgonervine if the BP is high. Oh, and here's a farm hack. High BP? No Methergin for me. It's cheesy, but it works. Honestly, sometimes the cheesiest mnemonics are the ones that stick when you're running on 3 hours of sleep and too much coffee. All right, guys, that's a wrap for today's whirlwind tour of L&D meds. If you survived this episode, you're already ahead of the game. We'll be back with more pharmacology adventures soon, so keep those scrubs handy and your sense of humor intact. See you next time.